Starting with this edition, we're experimenting with a new format. You'll first get a very brief roundup of the week's top stories from Physicians First Watch, read by First Watch's editor, Amy Herman, and then we'll proceed directly to the conversational stuff. We're experimenting on the fly here, so please let us know what you think and what we should change.
Here are the week's top stories from Physicians First Watch. First, a large international study shows that when it comes to outcomes in non-cardiac surgery, the riskiest time is the post-op period. Of patients who died, just 1% did so in the operating room, while 70% did so during their post-op hospital stay, and the remainder did so within 30 days after discharge. 3 perioperative complications accounted for nearly half of the deaths. These were major bleeding, post-operative myocardial injury, and sepsis. Next, in a comparison of different guidelines for evaluating hematuria, routine CT scans for all patients were found to be risky and expensive. Even though uniform CT had a diagnostic advantage, it led to more radiation-induced cancers and cost far more than other approaches. The American Urological Association currently recommends CT for all cases of hematuria in patients 35 and older, while other groups like Kaiser are more discerning. Elsewhere, the American Academy of Otolaryngology Head and Neck Surgery Foundation has updated its guidelines on sudden hearing loss. Among the changes, the guidelines emphasize that patients should have audiometric confirmation of hearing status as soon as possible, usually within the 2 weeks of symptom onset. In addition, corticosteroids are an option within those first 2 weeks. Next up, a study finds that SGLT2 inhibitors used for type 2 diabetes might not increase risk for severe urinary tract infections after all. In 2015, the FDA warned about this potential risk, but a new analysis shows that the risk is no higher with these drugs than with other diabetes drugs, like DPP-4 inhibitors. In rounding out this week's list, patients who use acid-suppressing drugs like proton pump inhibitors might be at increased risk for developing allergies. An Austrian study found that patients who filled prescriptions for acid-suppressive drugs were about twice as likely to later fill prescriptions for anti-allergy drugs, compared with patients who didn't use acid-suppressive agents. And that's it for this week. Now, on to Joe Elia's latest clinical conversation.
This is Clinical Conversations. Chronic kidney disease is a prothrombic state. In addition, atrial fibrillation is highly prevalent in this population. Yet there is relatively low use of anticoagulants in these patients. With those observations, Dr. Sunil Badve and his co-authors introduce a meta-analysis of oral anticoagulant therapy in chronic kidney disease, that is, vitamin K antagonists and non-vitamin K oral anticoagulants, or NOACs. It appeared recently in the Annals of Internal Medicine. Dr. Badve and his co-authors sought to evaluate the benefits and harms of oral anticoagulant therapy in patients with advanced chronic kidney disease, stages 3 to 5, including those on dialysis. Dr. Badve is a nephrologist at St. George Hospital and a senior research fellow at the George Institute for Global Health in Sydney, Australia. Welcome to Clinical Conversations, Dr. Badve.
Thanks, Joe.
So, if you were to say what your principal finding was in that meta-analysis, well, how would you characterize it?
We specifically looked for randomized controlled trials, and we excluded observational studies. And we were mainly looking at oral anticoagulants, either in the form of vitamin K antagonists such as warfarin or non-vitamin K oral antagonists. And we found a total of 45 randomized controlled trials, and collectively there were more than 34,000 patients. Now, out of those 45 trials, only 8 trials included patients who are receiving dialysis, and the remaining 37 trials included patients who are not on dialysis. Now, none of the dialysis trials evaluated NOACs, and what we did is, because there were so many trials, we tried to simplify the evidence by categorizing trials according to patient population that was included, patient population and indications for anticoagulation. So we had about 11 trials that included patients with atrial fibrillation. Another 11 trials included patients who had an acute episode of venous thromboembolism, such as deep vein thrombosis or pulmonary embolism. About 6 trials included patients who require prophylaxis to prevent thrombotic events. For example, perioperative patients who have undergone a major orthopedic surgery or those who are hospitalized for an acute medical illness. As I mentioned earlier, 8 trials included dialysis patients, and the predominant indication was prevention of dialysis access thrombosis. And the remaining 9 trials included patients who have cardiovascular disease, but other than atrial fibrillation. So what our meta-analysis showed that in patients who have atrial fibrillation and those who have early stage chronic kidney disease.
When you say chronic kidney disease, were you talking about patients in was it stage 3 to 5 disease?
So predominantly early stage. So predominantly stage 3 chronic kidney disease.
Okay.
But there might be a few with stage 4 chronic kidney disease as well.
Right.
But it's predominantly early stage, which is stage 3.
Okay. So I'm sorry for interrupting you, but you were about to talk about the findings for NOACs.
So in patients who have atrial fibrillation and early stage chronic kidney disease, NOACs were superior to vitamin K antagonists, with statistically significant reductions in stroke or systemic embolism, hemorrhagic stroke, as well as all-cause death. Compared to vitamin K antagonists, NOACs also significantly reduced the risk of major bleeding. However, the upper 95% confidence interval just crossed 1, so it's not statistically significant, but overall the results are in favor of NOACs compared to vitamin K antagonists.
Now your funding was not from the companies that make NOACs, but most of the trials of these drugs were sponsored by drug companies. But I just wanted to put in the statements that your research had no support from anyone. You say that correct in your paper. Okay, go ahead.
That's correct. Yeah. What our research also showed that in patients who have acute VTE or venous thromboembolism, compared to placebo, NOACs also reduce the risk of recurrent VTE or VTE related death.
Yes.
But the results were quite similar to that of warfarin. Mm-hmm. So in patients with acute VTE, NOACs might be a reasonable option.
Yes.
In those patients, and while our findings showed that NOACs were superior to vitamin K antagonists, most of these or all of these trials excluded patients who have very advanced stages of chronic kidney disease, such as stage 4, stage 5, or those who are receiving dialysis.
Okay.
So these findings really do not apply to advanced stages of chronic kidney disease,
right.
As well as those who are requiring dialysis.
So it's usually at stage 3.
That's correct.
Or lower. Okay. But you didn't evaluate, you didn't go looking for people in stages 1 and 2 kidney disease. You were looking for stages 3, 4, and 5.
That's correct. That's correct. Yeah.
Okay.
Yeah.
Now, why do you mentioned in the introduction to your paper that I think you mentioned Germany. There are only about 2% of patients who are on who are receiving anticoagulant therapy in chronic kidney disease, and in Canada it was something like a third of the patients. And why do you explained why you think that is so, and so why is it so unusual for people to be receiving these antithrombotics?
So first of all, that data was published about 10 years ago.
Uh-huh.
So it's not a recent data. However, we think that the recent data is going to be similar to to that was published 10 years ago.
Okay.
The reason why there is substantial variation in the use of anticoagulants in dialysis patients is because nephrologists or their treating physicians are uncertain about benefits of anticoagulant in this patient population. And one of that uncertainty comes because of increased risk of bleeding. Now, compared to people who have normal level of kidney function, people with decreased level of kidney function have increased risk of spontaneous bleeding, and that risk increases further if they are on anticoagulant therapy.
Okay.
And this risk is very high in those receiving dialysis.
Okay.
So it is not uncommon for dialysis patients to have presentations to emergency department with bleeding episodes such as gastrointestinal bleeding or intracranial hemorrhage. So obviously, nephrologists are very, very careful about using anticoagulants in this population. The other thing is most patients who commence warfarin therapy for atrial fibrillation will stop it within a year. For example, almost 75% patients will have discontinued warfarin therapy within the first year of commencement of treatment. We still don't understand what are the causes of discontinuation, but we think those are bleeding risks.
I see. So it's a kind of a paradox, isn't it, that the patients with in late-stage chronic kidney disease who are at the greatest risk from their procoagulation state are less likely to be subjects of clinical trials.
That's correct.
You must have searched high and low to find people to find those 45 trials.
Yes. So we could not find a single trial that specifically included dialysis patients or patients with advanced stages of chronic kidney disease that were evaluated in these trials.
Yeah.
All of that data comes from subgroup analysis.
Okay.
There are 2 or 3 trials that are currently ongoing, and we will be expecting results from those trials in a year or 2. But there are no published trials so far that included only patients requiring dialysis or those who have advanced stages of chronic kidney disease. Most of these existing trials have excluded patients with creatinine clearance less than 25 ml per minute or 30 ml per minute.
Generally, NOACs had a better benefit to risk ratio than the vitamin K antagonists.
Yes.
But you write that the evidence is insufficient to recommend widespread use of these vitamin K antagonists or NOACs in later stage chronic kidney disease.
Correct.
So what do you hope will happen now in the research that's done? I sense a call for more trials to settle some of these issues.
Yes, you're absolutely correct, Joe. We need to conduct large trials specifically involving patients who require dialysis or those who have later stages of chronic kidney disease, because their requirements are quite different than those who have, say, mild kidney disease or normal kidney function.
So for clinicians treating patients who worry about, with chronic kidney disease, who worry about this prothrombotic state that you identify, what is the best advice that you can give to them?
So people who have early stage chronic kidney disease, our research strongly suggests that NOACs should be considered over vitamin K antagonists.
Okay.
But those who have advanced stages of chronic kidney disease, in these patients, treatment should be based on individual risk-benefit assessment. Unfortunately, there are no published data on NOAC, so we do not advocate the use of NOAC until more data are available. But till then, anticoagulation should be, so the decision should be based on whether to anticoagulate or not anticoagulate.
Okay.
And that should be based on individual risk-benefit assessment.
I see. And so with the available evidence that you summarize in your meta-analysis, I think that you give a nice kind of complication by complication look at how the various anticoagulants are working, and you sort of warn in each one, well, this one seems to be working better. However, the confidence intervals are very wide.
That's correct.
And so I would refer our listeners to your paper to check those out. So, have you had any reaction from your colleagues to your findings? Were there any surprising findings, and what were they?
So the surprising finding is clear demonstration of superiority of NOACs over VKA in early stage chronic kidney disease.
Okay.
Because so far people have been extrapolating data from general population trials to CKD population. No one had done a comprehensive review like this before. So just discussing back to your previous question, if I can bring that question again.
Sure.
Although we did not cover in our systematic review because it was beyond the scope of our review, there have been a few pharmacokinetic studies published using other anticoagulants such as apixaban and rivaroxaban. And although there are no trial level data in this population, pharmacokinetic studies show that apixaban and rivaroxaban can be used in patients who are receiving dialysis, slightly at a lower dose. For example, apixaban can be used even at a dose of full dose, like 5 milligrams twice daily, and rivaroxaban can be used at a dose of 10 or 15 milligrams once daily, even in patients who are requiring dialysis. And these are approved by FDA in the US, but not outside the US. But we need to remember that that approval is purely based on pharmacokinetic data and not on any clinical data demonstrating efficacy or safety of these medications. So we still need to exercise caution when we are using these medications in advanced stages of chronic kidney disease.
There was an editorial that accompanied your paper.
Yes.
I'll bet you that you read it.
Yes.
and what did you think? Did you agree with their conclusions?
So actually the editorial was very supportive of all our findings. So it was not an unexpected opinion from the authors of that editorial. Okay. And in fact, we were very pleased that there was no severe criticism of our review. In fact, they agreed with most of our findings.
Yes, they mentioned the forthcoming studies that you just mentioned to me that are going to resolve some of these questions, and I will quote from it. From the editorial, they say, until the results of these trials become available, the decision to use anticoagulant therapy in patients with end-stage kidney disease will continue to require an individualized approach that balances potential benefits and harms. So, well, it was a successful foray into meta-analysis. It seems like it was a lot of work because certainly there were many studies to find and then many to interpret it.
That's correct. So it was a huge teamwork, and my special congratulations to Dr. Jeffrey Ha, who led all these analysis.
Okay. Well, I want to thank you very much for talking with me today, Dr. Badve.
Thank you so much.
That was our 227th clinical conversation. The whole searchable collection is available free at podcasts.jwatch.org. Let me know how we can improve these chats. Email me, jelia@nejm.org. We come to you from NEJM Journal Watch. The executive producer is Kristen Kelly. I'm Joe Elia. Thanks for listening.